I will present a case on real-world experience with high-risk DLBCL. And what I will do is I will discuss a bit sequencing of treatments and also discuss how we changed our view on who should now get CAR T-cell treatments. So here's the case report. It's a female patient, 59 years old, and we are in the year 2019. The patient had a diagnosis of DLBCL, GCB, double hit score 2, and had a clinical stage 4 with bone marrow infiltration, osteolytic lesions, and multiple other manifestations. The AAPI was high to intermediate, and the CNS IPI was 3 intermediate. She did receive 6 cycles of R-COP in a community hospital, but she was refractory to these 6 cycles. Then in 2019, in July, a lymph node biopsy was done and showed persisting diffuse large B-cell lymphoma. But what was new now were multiple CNS lesions. Remember, she also had a high or intermediate CNS IPI, and she was now referred to our hospital. At that time, second-line CARs were not available, so that's why we discussed, in principle, of course, autologous stem cell transplant, which was the standard at that time, or CAR T-cell in third line. That's why we, at this point, did successfully T-cell apheresis the patient, because we expected that after the next line we could deliver the CARs. And then we started a therapy for relapsed disease with a Burkitt protocol, according to the German protocol, because she had these CNS lesions, and she did receive intrathecal therapy. Surprisingly, she had a complete metabolic remission, and therefore now she underwent a stem cell harvest at this time. So we had both options, and she was in second CR at that time. So that's why the standard of care at that time was ASCT. We planned to transplant her. But while we were preparing for transplant, she did get another CNS relapse. She did receive triple therapy, and now, of course, it was very clear that we should go for CARs. The CSF was still positive after this intrathecal therapy, and she was radiated at that time. Another thing that we would probably today not do anymore, but I will explain why we did that, and CAR T-cell treatment was planned. So this is the status at the end of radiotherapy. So you can see that, where is it? Yeah, you can see that, of course, this cerebral lesion in the MRT did respond, but was still there. But unfortunately, and look at the date, so this is April 1, and this is April 23, while we were looking at the brain, the patient again had a systemic relapse. Again, something to consider. Now we finally got our CARs for this patient. We did bridging with rituximab, polatuzumab, and dexamethasone because of the brain issue. And she was infused in June 2020 with CAR T-cells. She had no CRS, ICANS 1 under Keppra prophylaxis, and she had a favorable outcome. She had, at month 3, negative PET-CT and MRI was negative, complete metabolic remission. I'll show you the picture. So this is the brain, and this is the response systemically. I'll go back. There were some toxicities involved, long-term toxicities. The patient developed IgE deficiency and was substituted until these days. And there's one special issue with this patient. She did respond to SARS-CoV vaccination. Not all patients will respond after this type of treatment. At that time, she had 6% CD19 positive cells. And there's an update. I saw the patient in April. She is now in complete remission for the last 3 years, now has 13% CD19 positive lymphocytes, but still some circulating CAR T cells. So The reason why we treated this patient this way at the time in 2019 was because our countrywide recommendations would not allow to treat this patient immediately with CARs because there was a special requirement that patients should not have active involvement of the CNS at that time. That's why we didn't treat her with CAR T-cells right away. We did amend in the meantime, of course, with more data coming in, this particular paragraph. And if you look here at the right side, today, we would definitely treat this patient in second line. We would not radiate the brain at this time. And we have much less stringent rules, of course, now for CAR T-cell patients in general and how to treat them. So things have evolved quickly within the last 3 or 4 years, and that's really the good thing. On the other hand, by using these algorithms, we of course have selected for some not so bad risk patients, and these are the Austrian data presented at ASH last year by Jakob Butzky. So you see that we have a PFS at 12 months of 64% and an overall survival of 75% after 1 year for this population. So I conclude, special populations, including secondary CNS lymphoma, can definitely be included in CAR T-cell treatments. The sequencing has rapidly changed, and we will see how it will evolve with all the new treatments coming in and how the sequencing will now look like. Second-line CAR Ts are available. A secondary CNS lymphoma can be successfully treated and of course, preferably in CR, but this is not mandatory anymore. And of course, with the second-line randomized studies, CAR T-cell treatment is now the standard of care. And the advantage, of course, is also that a CR is not required. If you have any questions, I'll be happy to answer them right now.
Yes. I just have one question for you. Thanks, that was a very nice case, and I'm good that the patient did so well with such a presentation. I'm just curious about the polatuzumab that was used before the CAR T cells, and I think in the US it had become a standard to give Pola BR before CAR T cells, but now, of course, after Polarix, polatuzumab is approved for frontline treatment. Do you think, what is the importance of pre-CAR T cell treatment, and do you think that makes any difference? And with polatuzumab being used much more in the upfront setting for patients who relapse after polatuzumab, what type of next therapy should they get before CAR T cells?
Well, cannot definitively answer the question. We, in our center, and we've published that, like many other people, we have good data that T-cell quality in diffuse large B matters. So, of course, that's one of the reasons why, and bendamustine is the killer. I don't think it's the polatuzumab. So with the Polarix, we will see, but I don't think that that will impact very much on the T-cell quality. It's more the benda. And for the bridging, we use our Pola benda still, even for the bridging. We haven't had many patients who have had a Pola before, but it's still our preferred bridging treatment. In this patient, we substituted the benda with dexamethasone because of the CNS issue. Okay. But other than that, our Pola benda is our standard bridging. Yeah, Michael?
So how do you reconcile that the CAR T cells are around and still CD19 positive B cells are coming back? And in ALL, that would be an alarming sign, and then see that as an early indication of relapse. Is that something that you sometimes see in patients, and you feel comfortable with this? When
at this low level, yes. There's still some CARs, and they may not even circulate. They may be sitting somewhere in the lymph nodes or wherever. Yes, but of course, over time, I do expect that in this patient, the CARs will fade out probably at some point. I mean, it's also the other way around. In the lymphomas, we detect a lot of CAR T cells in relapsing patients. Almost everybody still has CAR T cells around while the relapse is already coming. It works both ways, fortunately or unfortunately.
Yeah.
Yeah.
Good.